again to the DF MPC CHSE professional learning series. It's nice. Today we're going to start off with a new on a new theme, a triad of sessions involving the Journal Club Learning Workshop and Tech Tuesday. And today we're very pleased to be kicking off with the Journal Club around the theme of feedback. And delighted, Hilary, that you can join us. Really, thank you so much for your time. And we really are pleased, not least for the fantastic work that you do for us and all of our students in the Sim Lab. It's a real opportunity to see you on a different stage here in our Journal Club. So thanks so much for your time today. And I'll hand over straight to you. Thank you so much.
Oh, well, thank you, Richard. Thank you for the intro. So I chose this article today about feedback and taken from a different perspective from SPs giving, it's our standardized patients giving feedback rather than being a facilitator feedback. So what I've experienced in my years at FITS and in the health sciences, that feedback usually is facilitator or assessor given. And not really, it doesn't offer the opportunity for students, for patients to, for students to get the feel from the patient's perspective as well. So also why I thought this article was quite relevant at the moment is that also post-pandemic now, and with last year and the last 18 months, our students have had they've had reduced patient contact, I feel, and then also they've had, and I do believe that they've had reduced sort of supervise of the physicians or the clinicians haven't been able to give them as much supervision possibly as they would have sort of pre-pandemic. So this has led to, and I've seen this in the Sim Lab, so the students are quite. They are not, they're not as confident as they, and for various other reasons, as they were sort of pre-pandemic. And I think that they're quite, the need for clinical feedback for them is feedback on their performance is actually vitally important as well. And we have standardized patients and we have simulation patients in the which we use in the university and in health science. So I don't know. Does everybody know what? And the article did explain what a standardized patient was, but is everybody? Does everybody know what I'm referring to from it? Or, it's a patient that it's a layperson that can sort of take on the role of a patient, but just to go back to why I thought this article was quite relevant at the moment is that our SPs or standardized simulated patients that we are using, to me, and I might not be completely aware of anything else, but our SPs are sort of mainly used as bodies for patients to hear chest sounds or to answer. They stick to their script which they do need to, but they're usually used as a prop for clinical teaching, rather than for to mimic patients as such. So many years ago in 2014, I did try and run a simulated standardized patient training program for our SPs, and I must admit very limited success with it. And part of my training was to try and empower them to give students feedback, but they couldn't. I think that they just couldn't overcome their belief that the health sciences students were there and they were there, and that there wasn't any, whatever they had to say would not be of relevance at all. So that was that was my belief. So that's also why I looked at this article, thinking, there is, maybe we should look at it again. But the article uses students and faculty members in their clinical trials, in this randomized trial. So that's also a possibility, because I believe that if we use students as SPs, they would learn from that encounter themselves as well, and they can give feedback, as well as looking at training some of our SPs to give students feedback from a patient perspective. The article also mentions the two aspects, which I think is so important, and I noticed in most of our students, they don't know how to get informed consent from patients. They sort of explain the procedure and they say, "Is that all right? Can I continue?" Which really isn't informed consent, and I think that this spills over into our patients. Many of our patients, I believe, don't really fully actually understand why they're in hospital, what the procedure is, what's going to happen to them. They're not actually fully informed about the procedure, and hence they can't give consent. But where in our curriculum can we manage to give our students feedback in this vital area? Because, and on all the ASCIIs, the first line is, did our student introduce themselves? And they do that beautifully. And then did they explain the procedure, which is sort of 2 sentences? And then did they get consent? And it's a mark, and that's all it is. So. Okay, Shira's asking. Sorry, Shira, it sort of popped up and went. What did you ask?
Sorry, I didn't want to put up my hand because you were going in such full flow, and it's so cool.
Sorry, I'm a slow dancer.
No, I'm just interested to know, and maybe you can give your take on how they actually train the SPs, because I agree with you. It's such a useful resource for us to have, particularly for the student, a feedback of a knowledgeable, say, patient. And so in terms of practice, were they given also a checklist of things to look for, or maybe you just want to unpack the idea of what good feedback is compared to feedback that students could or may ignore? How did they make the feedback meaningful?
So the training that we did with our SPs was that we really asked our SPs. We gave them a checklist, just not even a checklist as that they had to not like a Likert scale, but they had to really think about. I can't remember now, about 6 things on it. Did the student make me feel comfortable? Did the student communicate? And the last thing on the issue was, do I fully understand what this consultation will be about? And that's the one that that most of our SPs gave very low marks for. It was, did the student make me feel comfortable? Did the student communicate well? Look me in the face. Did the student use language that I understood? They gave good marks for that, but at the end of it, they still really didn't understand what the student, what the purpose of the, not the purpose, because they would have been there for a reason, but they didn't fully understand the consultation. Does that help? Does that answer your question?
Yeah, it does. Thank you. And I think that that's a meaningful point, because when students think about feedback, they think about the classic, what went well in this session, what did you think could be improved in this session, and so a relatively formulaic thing. And I think that what we're trying to say in terms of clinical training particularly is to bring in an element of reality, to say, and that's what patient feedback brings. It's not facilitator feedback, it's from the patient side. Yeah. If I was a patient, how would I have felt being given the treatment you're giving me? And I'm wondering if that's more real for students than the classic, even in the sim lab or watching videos, etc., where we give this straightforward thing. And to try and delve a little bit deeper, that concept of reflexivity. So being able to think, what was my approach to this, and how does this information change the way I feel about what I'm doing? Rather than just, okay, move on, as you say, tick the box. We got that right. We got that right. Well, next time. So how do we deepen it is my question to you.
Well, that's sort of what I was thinking, why I sort of also looked at this article, because I think that students, SPs are hugely valuable. They are in the building, and there are some excellent SPs who I really feel could offer the students the feedback about the authentic patient experiences that you really spoke. You really spoke to me as a person, and I really understood what it is. And I don't think that the OSCE situation is, they did it in this article, they did it in an OSCE situation. They had a mock OSCE, I think, first of all. Then they did it at a mock OSCE. But I think, and maybe Stuart can help here, but I think it would be more in a learning, in the clinical skills teaching environment. Stuart, do you use SPs in that environment, and do they give feedback to their students?
So we used to use SPs in the teaching environment a lot pre-COVID, but obviously looking for ways to keep our numbers down. We haven't done it in a while. And I think we actually missing it, because it was always really nice to get some thoughts from the simulated patient's perspective when the teaching was happening. Even in our OSCEs, even if the student has left, we get feedback from the SP as examiners to help us with the way we mark the students, which is also incredibly helpful. But I think we're missing it, and I would like to go back to having the simulated patients involved and giving some students feedback from the patient perspective.
Yeah, I think it is very valuable. We do one fourth year nursing OSCE where we ask the simulated patient then to then give the student a mark out of 10. And there's 10, I think there's 5 things, so it's 2, 1 or 0. And they completely overinflate the mark. I think that they feel sorry for the students. So that's why I think that the OSCE situation maybe isn't the best area to do it. But I think did when you were using them pre-COVID, those SPs for feedback, did you have like a bank of SPs that you used for feedback? Because some of them I find they can't do that. Sort of they feel very intimidated.
Yeah, luckily we've been working with our SPs for a while, and then you get to know the personalities that are comfortable to give a bit of feedback. But luckily we've sort of built a relationship where we've had the same group working with us for a while, and then you know who are the people that are happy to give the students feedback and who doesn't really want to be put on the spot. So it helps to get to know the SPs quite well as well.
Well, that I think is a very interesting thing, because then we should I think that maybe when we're running clinical skills, is that we need to refer back to you and to utilize those SPs that you feel are, that we must share the information across the faculty so that we really get the best. Shira asked if we use the drama for live students. Shira, we did. We used them. I don't know if any other faculty did, but we used them. But I remember when Rainey was in family medicine, she and I sort of looked at it. the trouble is that their schedule and our schedules just didn't really coincide. They were in exams when ours were in exams, and we needed them for exams, and they were good when they were available. We had to we should have looked at making it more of a credit or something like that for them. From that perspective,
I think that's a pity, because if we're talking about building up the faculty resource of a group of SPs who understand that when they come into it, yes, they do have to go through the process with all the students, but that they'll have to give feedback. And I love Stuart's idea of extending it to feedback to the examiners as well as perhaps feedback to the students. In the article, they only did it one way. Am I right? They didn't speak to the examiners. They gave feedback
to the
on the students. Yeah.
So it was more feedback. Feedback for learning, in the mock OSCE, and then they just looked at it in the second OSCE when and the improved, and there was quite an improvement in what was it, in clarifying, summarizing, and ensuring closing properly. So I really feel that the article is, or to me, was very valuable, and that it really has sort of rekindled my sort of thoughts about maybe really starting another, maybe a simulated program, a training program on feedback for our simulated patients to give to be able to give feedback to our students. Does anybody else use SPs for feedback?
So I guess it might just be the therapeutic sciences or clinical associates, maybe. So maybe we need to backtrack and just have a look at this concept of how can we help students to understand the feedback so that it's more meaningful for them, because particularly you remember the work that Andrew did in his master's, Hilary, when he was talking about formulaic feedback, how our students really just wanted the mark. They weren't so interested in going over each part of the skill, and also how students kind of forget what they've done. So in some of Hilary's work in the sim lab, it's been quite interesting to see when the sessions are videoed and the panel then sits afterwards and can deconstruct what has gone on in the simulation. They're students who don't know what happened. And when they actually see it on video, they can't believe some of the actions that were taken. So I just think that this area of do you give feedback immediately, or do you wait a bit but then they've forgotten, or do you wait a bit and then use technology? What's one of the good ways? And I think here with SPs it's more real life, but I do think that in terms of clinical training there has to be a sweet spot where feedback becomes meaningful to help them improve.
I think that feedback should be as close to the encounter, close to the clinical learning experience as possible, because then I notice the students do go, aha, yes, I agree with that. Sorry, somebody's got their hand up. I can't see.
It's Prof. Jacobson.
Hello, Prof. Jacobson.
It's Mervyn, and thank you very much. And I'm absolutely excited by this. I was introduced to this concept of SPs not very long ago. It was a new experience for me to have an SP. And I found it very valuable to get the feedback from the SP because they observed things that perhaps I wasn't concentrating on. I was concentrating on the academic stroke clinical input, but the SPs gave me feedback on things like body language and voice and sensitivity of touch and gentleness in communication. And for me, these skills as a clinician are absolutely critical in terms of how we create a relationship with a patient. And having got the feedback from the SP, I was then able to go to the individual and say, hey, you were very aggressive, or your voice tone or your body language are not conducive to creating good relationships with patients. So for me, SP is an absolutely critical part. They were used in OSCEs. In the old days, and I'm talking from a geriatric point of view, we had live patients. I don't know if they ever asked the live patients about how they felt about the students. But from an SP point of view, I feel it's an absolutely critical and integral part of evaluating holistically, not only the academic knowledge, but the interpersonal skills of students. Thanks.
Mm. No, I agree totally with you. I think that Shira was giving the example that we used when we filmed students working with SPs, and this it was actually the one really that we were very aware was that the student had her face really in her checklist, kept sort of going over her checklist, going, have I done? And our SP was fantastic. She was sort of getting more and more uncomfortable. She had an abdominal pain started, and she was really writhing with the pain. And the student completely missed it because she was so busy going over her checklist in her head. And when the SP gave her feedback, the student really didn't believe, just didn't say, I don't recall doing that. We showed her the video, and really that was when the learning did actually occur. And we just literally filmed it on our iPad, so it wasn't a huge technically sort of expensive exercise to do. We did it on our iPad, and it was an amazing learning opportunity for that student, in that she just was not aware that she had done that herself. Mm. So I also think that feedback, what the beauty of SPs giving feedback as well, one of the bonuses is that it's mostly perceived by the students, I think, as being non-judgmental. It is what it is. That's how I experienced it, and I'm telling you how I experienced it. Often students, I think, perceive feedback from facilitators or clinical supervisors as possibly more judgmental than what we intended to be. And also our feedback, we often overcorrect them. We say, oh, you shouldn't have done it this way, you should have done it that way. We don't our feedback doesn't sometimes give the students space for them to work it out for themselves, what went wrong or what went right as well. Does anybody have that experience?
So Hilary, I love that idea, because it's always they finish doing what they're doing and then the feedback comes, and it's my turn to speak and your turn to speak. And I think that it's a really valuable thing to allow students to not just say for themselves what they thought they did right or where they could have improved, but to really develop some reflection so that they're not relying on you to say whether they were right or wrong, but they're trying to think it out for themselves. I see that Prof. Cook's talking about the difference between simulated patients and expert patients. I don't know that we've got the funding to go for real expert patients.
Yeah, I mean, maybe not. I mean, does, when I just wondering as to in many different medical schools and different disciplines, departments around the world, they've got this patient who has such excellent signs of X and another patient who has excellent signs of Y, and they do bring them in. Yes, as we've moved to more of a simulated patient than real patients, as opposed to expert patients, then the opportunity for that, for having the inputs from an expert patient then falls away. I mean, I know that the ethical considerations, are they not, colleagues, of particularly in pediatrics, of course, of having real patients in an assessment context. But what I'm interested in is in terms of the simulated patient who could then potentially be an expert at feedback. What is it that we're missing for them not wanting to do it? Because maybe, Hilary, they've picked up on years of us being the judgmental ones. I mean, is that not a real slight on what we're doing as clinicians and trainers, that we are perceived to be so judgmental in giving feedback? It really is quite depressing that we should be defined, but it's the reality, is it not? I think. I mean, if we were to move all of it to formative assessments as opposed to summative, then perhaps we'd be in a much better environment to begin with, or relationship to begin with the student, that could get us off the hook a little bit. I don't know. Maybe we'd still be as judgmental. I don't know.
So have a look at what our viewer said in the chat. And that's exactly Richard's point, is that the SP is looking to the facilitator to say, check this out, she's done it wrong. and then waiting for the facilitator to swoop in and say, hang on, this is not the right way, or whatever it is. Hilary, what about that one where, the students are doing something and they're going to kill the patient in the sim, but we don't want to model that, okay? So we want to save the patient's life. And you charging in and saying, let's all stop and think about this now.
Well, I know that Stuart and I have this ongoing thing about these. He says, let the student learn from the mistake. And I say, no, we need to, we're not doing end of life training here. We're just doing, I say time out, sort of, and we reset. I try and reset the student group, or the student and the SP to, or even, I mean, it might not even be end of life, or that the patient's going to demise. It might just be that the whole interview's sort of gone off in another direction, on a different tangent to where we have. So, and I just say, let's just reset, let's just regroup. And then what I actually do is that I take the SP, sorry. I take the SP out of the room for a bit. I sort of separate them for a while, and then not separate, but I just speak to the SP and I say, listen, in that situation, maybe could you say, if she asks that again, just say this as a prompt to get it, because sometimes the SPs don't have that depth of knowledge that they need to be able to think sort of more broadly. I do time out if necessary for it. So, but I was just going back. I just want to go back to Richard and the expert patients. I think that we need to have a bank of expert simulated patients that are trained in communication skills, that are trained in certain procedures, the common procedures across the faculty, where they really become experts in expert simulated patients, and they can be used across all the sort of faculties. Have a training program for them.
So that's a nice idea, Hilary. You know, that we could have a resource for the university across all the faculties, and I'm sure there are lots of places where SPs would be useful. But I'm interested in the idea of using peer feedback, because supposedly your peers or people in a class above or below you should be able to model what it is you're wanting the peer to pick up. So is there a way you can think of that we could involve each other in clinical skills training so that the feedback is more real, and also so that the encounter becomes more real, because the student to student would then know what to ask or what to model or what to, you know, exhibit. I don't know. Is there a role for that? Why don't we do that more?
Do any of the faculties use peers? Peer sort of the other students as SPs? I'm not sure.
I don't think. I mean, if anyone does, can you put a hand up? I don't think any of the programs really do it, and I'm wondering why we don't. Oh, V wants to say something.
Good afternoon, all. When I was teaching advanced trauma life support, we did get groups of 2 or 3 students. One was the patient, one was the actual doctor, and one was the assessor. So we used to get 3 feedbacks from each of the people in our ATLS training course. That gave us so much of insight on what went wrong from the patient's point of view, what went wrong from the doctor's point of view, and then the assessor acting as a teacher. So maybe that's a very good thing, to have other people assess you while you are assessing your students.
So did they do the assessment, or were they providing a feedback, just verbal?
They were providing feedback, because once they finished the session, the last 10 minutes of each rotation, like just say I was doing airway management, then the last 10 minutes of the feedback, everybody was awake talking, telling us, okay, from your assessor's point of view, what do you think could have been done better? What do you think wasn't performed to perfection by the patient or by your doctor? And then we get each feedback from that way. And then we know who is competent at the end of the exam for that practical. So that was a very good idea. I think the ATLS way of doing that and the assessment gives us a foreground on what capabilities each student has on their reflection, obviously, because they know where they went wrong.
And they do, and I think ATLS is very good, because they actually have feedback on the skill, and then they have feedback on the communication level as well. Well, in APLS, that's what they do. That they have somebody observing the communication, and then somebody observing the skill together, and then they give the oral feedback, and then they get the participating students. They get a very good overview of what, you know, of how it was perceived by the onlookers. Yeah. Observers.
Yes. So I think that's very important as the point of reflection.
It is a nice way of doing it. It is a good way of doing it. Shira, you asked if we do peer-to-peer feedback. In simulation, we do in the debriefing. We ask what went right, what didn't go, you know, what would you do differently, what. But it's not really about it's not about communication. Might come into it, but it's not primarily about communication. The students are quite quick to pick up on technical problems that they had. It's not the soft skills that I think are so missing in our students at the moment. It's they give feedback on the technical aspect of the simulation. Oh, you didn't put up the IV fast enough. The patient's sats were dropping and you didn't notice it. It's technical rather than communication at the moment. Yeah.
So I think that brings us back to Prof. Jacobson's point, that that the knowledge domain is really what they're looking at and what the facilitator looks at, but the simulated patient could give you access to that whole affective domain, the compassion and the care and the real worldness of being a carer. And that's something that you can't give a mark to. and so the students need to take it seriously from some source. Prof. Cook has his hand up.
Yeah, yes.
Right. I just wanted to share that I'm of the view that for a Faculty of Health Sciences, that feedback is the single best instrument by which we can have quality, a quality product. It's not curriculum, it's not learning outcomes, it's not assessment, it's not training, it's not anything, it's not sites, it's not. Now all of these things have to be in place, but surely the real critical thing is feedback that stands at the top of the pile, because it's the response to performance, it's response to it's the reaction, it's the immediate reaction often, or a little bit delayed, by which one can, a student knows where he or she is at. So if now, yes, that's a personal view, but for that personal view, I think that this discussion is really interesting for me, because I believe it's important that as many different players, stakeholders in the training environment, assessment environment, whatever, are given and the opportunity and are trained up to give feedback appropriately. So it's peers, it's SPs, it's clinicians, it's faculty, it's just everybody can be schooled in the appropriate way to give feedback. Surely, I mean, I think it would be great if we could do that. And yeah, it'd be nice if we could start up that project of yours again, Hilary, in that regard.
I would actually find the file. I was actually meaning to look for it today. I had a file on it and how we and you know how we went about it. We used we did use a training, a sort of an outline. I must get it out again and see and refresh my own memory on it, how we did it. But I do agree with Stuart is that our SP program has grown over the years, and that we have some really great SPs that we could train up nicely. Sure.
So I agree with Richard that I think that feedback is key to producing any kind of professional, but specifically in the clinical sciences, and that you can have feedback from everywhere. And if we take a look at the model that a lot of people are very fond of, looking at Leuven Wenger, developing a community of practice. So our students are legitimate peripheral participants. They're here because they're students and they're in the environment, whatever that environment is, say the ward. But the feedback that they get doesn't have to be overt, because Leuven Wenger say that learning happens by participating in the practice. So here they are on the ward doing whatever they're doing, talking to a patient, interviewing a patient, writing notes, watching how the cleaner cleans the corners, speaking to the nurses, seeing how people take bloods, etc. So the feedback that they get is not only subtle cues from the staff working in the wards doing things correctly, but also self-feedback. They think, could I do that? Is that part of what I know how to do? And should I put myself in the position where I learn how to do that? Completely aside from having to go do a skill, show it to your facilitator and get feedback on it. So by virtue of being in the environment, but being reflexive in the environment. So part of also, I mean, Stuart's very fond of COLP, or Hilary also talking about doing the exercise, then really thinking about it, then thinking how you can do it differently, or taking the feedback, or critiquing yourself. And I think that that's a huge element of developing a practitioner who will be successful, because if you can't critique yourself, if you can't, first of all, be honest with yourself, but second of all, see your own faults, how do you improve? And then how do you then become that lifelong learner? Because for sure, there'll be a million trillion other things that you need to learn when you're out there. So you shouldn't even have to rely on feedback within the system. So, sorry, Richard, I've just got carried away with your whole idea that feedback is the core of our training, because I think even if we're looking at it as that praxis, that here you are immersed in the work environment and that's where you're supposed to be learning from, it doesn't just have to be that your superior says to you, oi, you've done this wrong, or change this, or hold your hand differently, or whatever. It's part of being, of understanding the being and becoming of where you fit in that process, and hopefully you're moving towards the center to become that master yourself.
But I think that we're in agreement that the facilitator needs to be able to provide the cue for feedback, to encourage the student then to be a reflective thinker. But the students often just want the feedback to be, this was right, that was wrong, this is what you need to do. So, and I think our more senior students are much better at getting feedback that encourages them to reflect upon their own actions and their own learning and their own responsibility to themselves for learning. So I'm not prof. Thankfully.
So I'm just interested to know from you guys who do the clinical training, and V, you'll come in a minute, is that when do you think your students have that aha moment of, I am responsible for my own training and my own self-feedback? Because sometimes that's the biggest wake-up moment that they have throughout the course of their professional training. V, you want to come in?
Yes, thank you. From when the MaxFax department did training for our BDS 5 students, we have reflective feedback from our registrars, our most junior registrars to our most senior registrars, on the group of BDS students that came in for that rotation for that week. We asked the BDS 5 student, what did you like about the week? What did you think about our registrars teaching you? Not the surgeons per se or the consultants per se, but our registrars showing you the way. You know, do you like peer review from being taught from other students in the discipline? Not as like they are senior to you or junior to you or whatever, but reflection from that point of view. And then during our oral exam, like on the last day of the week, after the rotations, we sit with the students and ask, did you learn well from our registrars? What do you think came across very well? We get so much of good reflection and good feedback from that every year we continue to change, and we try and motivate and incentivize for that change to occur during the rotation program. So I think our students, and I think we are getting it right in the MaxFax department. I don't know about other disciplines, but from the MaxFax departments, and we also got a written assessment where our registrars will sign the forms as to competence and asking questions, answering questions during rotations. And then during our oral exam, we only focus on patient management and what went right during our patient and overall management of a patient to incorporate everything they've learned in dentistry. So from that point of view, I think we are very good at reflecting on what our registrars are doing as well as our undergraduates are doing. So I'm hoping we can continue in this vein, and maybe next year we can actually do an assessment, a formal assessment regarding the feedbacks from both the registrars and the undergraduates. Maybe that will help. Just ideas, sorry.
Yeah, no, I'm to be thinking about them because they were great. I think from my own perspective, I think the more senior the students are, the more they become sort of, as they get towards their final undergraduates, the more reflective they become on their own. I think in the junior years 1 and year 2, is that they're very they're very directive. They need feedback, sort of direct. They want and they need directive feedback from us about about their skills, really. And then as they get confidence in their skills, so that they become better reflective practitioners, and how they approach the patient in a more holistic manner. But I think in the junior years 1 and 2, I think it's very I don't know if that's completely possible. Mervyn, Prof. Jacobson, Prof. Merv.
Thank you. I absolutely agree with the value of the feedback, but my question now comes is, do we as educators need training as to the most appropriate way to give feedback, considering, as you point out, that we're dealing with different both intellectual and emotional development, and the method of giving feedback needs to be constructive and positive and supportive, irrespective of whether there are negative results. So we don't have to say it's a bad thing. We can point out that other methods are preferable and this one may not be as valuable or as constructive. I'm being very verbose, but hopefully I'm getting the message across.
No, yeah, give them alternatives to think. Richard, I see you got your hand up.
Well, just to say that we should all be trained in appropriate ways to give feedback and the models and the frameworks of feedback. I know that it forms a key, well, it forms certainly a key component of the diploma, does it not, Shira, in terms of ways to give feedback? Is that correct? Well, certainly we run train the clinical trainer course that I'm in fact doing with the South African Academy of Family Physicians in 2 weeks' time again, and that we have a big focus around giving feedback throughout the course. And there's all the literature is supports there always being something positive you can say up front, something constructive up front. I remember just last week I complimented a student on his posture. And so I say that slightly tongue-in-cheek because he was a very bad student clinically, but you can always get that relationship between you and the student off to the right start. So he's going to listen to you about the constructive ways in which he can be improved, not where he performed poorly, but where, that he did badly in, or that it's a judgmental issue, but set up for the constructive criticism appropriately. I think we really must embark on a faculty-wide training around how to give feedback appropriately, colleagues.
Now, I think that would be very valuable as well.
I agree. So I think there's space for doing that separately. We in CHSE we used to run separate, bedside teaching workshops, just a 2-hour afternoon. And we've done various engagements with different departments like ONG at Barra, PEDS. So working with specific teams on how to improve their feedback or critiquing their feedback. But yeah, you're right, Richard, it is also interleaved in our PG DIP, and also by modeling, because in the PG DIP we give a lot of feedback in the learning along the way. And although that's not clinical teaching, it's part of helping people to change their approach and attitudes and look at things differently. So I think there's a lot of opportunity, and maybe it's something we should concentrate more overtly on, particularly in this day and age of synchronous teaching online versus face-to-face teaching. Another challenge. Sorry, Hilary.
And sorry to interrupt. And I think that also the use of technology, the use of videos is so valuable, because it reinforces, even if the facilitator hasn't said it directly, it sort of trying to get the student to think about, as Mervyn said, that how they address the patient, the use of touch, the gentleness, just demonstrating respect for a patient. If they're not, they can visualize, they can see it using a video, using a video recording of themselves, and it can be more a sort of a guided feedback, a guided reflection on their approach to the patient as well. So I think that we should also think about using, especially with our SPs, where it's the ethical, using patients is ethically fraught. But I think using SPs and videoing and building in time for the student to be able to relook at the video as well. Sort of a guided session is very, very valuable as well. Richard, I see your hands up. Was it an old hand? So.
Yeah, it is his historical hand, sorry, but really enjoying this conversation.
Yeah. So I think that it's, I think that we need to, and I agree that feedback is one of the greatest learning instruments that we have, one of our greatest, for students, one of our greatest teaching instruments, and one of the students learn the most through feedback from it, and that we need to perfect our own skills at giving it, and we need the time to be able to give. It takes time to give worthwhile feedback to students as well. Yeah. I see Yanis said about a culture of feedback.
So, colleagues, what shall we draw that to a close? I'm not sure if there are any other comments or inputs or questions. I think this has really set us up nicely for our next couple of sessions as well. Are there any final thoughts or final comments?
I agree with Yanis, this culture of feedback. I think that's what we really need to, and to give a more sort of non-judgmental feedback as well, because sometimes we're very quick. We're in a rush, so you think I must just correct this quickly before they leave my sort of room or whatever. So, thank you. Sure, a new flavour of yogurt. What's that?
Sure, you've got to help us with that. That's a fantastic way to finish off a professional learning series session.
We're developing a new culture, right, guys?
No,
sorry.
No, that's a leap too far for this time of the afternoon.
I agree.
God, you're still firing on all cylinders.
Happy Tuesday, everyone.
Well done. Well done. All right, brilliant. Well, Hilary, thank you so much for your insights, and really appreciate you leading us in this discussion. As I said, I think we've really set ourselves up for an engagement over the next couple of sessions around really some techniques of giving that feedback and some tools and frameworks perhaps we can talk about in the learning workshop, if not Tech Tuesday or whichever. Well, yeah. So this is, I think, a really important theme for us as faculty within this professional learning series. So thank you again.
Thank you all for your time. Have a very pleasant evening, everyone.